Hello, everybody, and welcome to this month's IMV Imaging Journal Club presentation. My name's Sam. I'm one of the vets here at IMV, and this month we'll be looking at a paper which is my choice, which is the ACVR and ECVDI consensus statement for the standardization of the abdominal ultrasound examination. So if you haven't joined us for Journal Club before, welcome. Just a really quick recap on how it all works. Each month, a member of the IMV team will choose a topic or a paper and to create a presentation on that, either kind of an appraisal of the paper or a critically appraised topic. And we put that presentation out to view on demand every month as well too. So if you haven't seen them before, you can check out the previous episodes on our website as well. But we want to hear from you. If you've got any questions or queries, if you have any comments as well, you can send them to us on clinical@imv-imaging.com, or you can also pop them in the question and answer box as well. So as I said, this month is my choice as well. I thought this is something really interesting and relevant that we've sort of seen come through from the ACVR and the ECVDI, which is this standardization of the abdominal ultrasound exam and consensus statement as well. So this was published in Vet Radiology and Ultrasound just this year as well too. So very recent, recently brought it out, and I thought it was a great thing to discuss and to look at it as well. So what is the consensus statement? Well, the sort of consensus statement from these organisations is just providing veterinarians with a set of imaging guidelines and a sort of appropriate use criteria and things as well too. So they put them out a sort of blanket statement about the way they do them, looking at interventional imaging procedures or radiation therapy, etc. But the overall aim is to hopefully improve the delivery of veterinary care for patients as well. And this particular consensus statement is about defining what is the standard for an abdominal ultrasound examination in cats and dogs. So how they did this was done by a committee of board certified radiologists as well. The authors are all based in the US, I believe. And what they did is they created a list of content associated with each topic as well. So they took a lot of sort of the kind of topics, the items that we'd associate with this abdominal ultrasound exam, and they created this list of everything they wanted to cover. And that list was sort of transposed into a survey that they could send out to the committee, basically create a sort of list of statements of which they could agree on as well. On average, they went through the survey and they agreed on about 78%, 80% of the items. And where they didn't agree with this sort of statement with the survey, the members had to comment on what they disagreed upon. And any of those sort of disagreement comments were kind of taken into account. The survey was amended and then repeated until they had a consensus on all topics. They also met 3 times for discussion to discuss any points in detail that they felt they needed to sort of cover, and they sought input from the members of the 2 organisations as well, to the American College of Veterinary Radiologists and the European College of Veterinary Diagnostic Imagers as well. So the result is this statement that they describes the recommendations for full abdominal ultrasound examination in dogs and cats. It doesn't address point of care ultrasound examinations. It's not surprising. Point of care examinations are about answering a very specific diagnostic kind of question, and they're a different entity to doing a standard abdominal ultrasound exam as well. And they do note that there are situations where a standard abdominal ultrasound exam will not be able to be performed, in things like where there's issues with patients' health or compliance as well. And they note that exams limited to specific organ systems are sometimes used, but a standard of care should be a full and comprehensive ultrasound examination as well, which is absolutely something that can agree with and get on board with them. It's a lot of these times, if we're doing an abdominal ultrasound examination, we want to do it in a sort of full and systematic way. So they go through and look at some of the recommendations that came from it as well, just summarising them, just for your sort of interest as well. So the first of us was looking at the equipment as well. So they were sort of recommending transducers with frequency ranges of 5 to 18 megahertz. Interestingly, what they did, which is not always as common in sort of general practice, is they sort of recommend that people are using different transducers for different areas as well. So in addition to having a convex transducer with a mid-frequency range, they suggest it's very important to have a linear design to look at those superficial structures, and a curvilinear design with a lower frequency range for larger patients as well too. And that as we sort of often will discuss, we've watched many of our kind of IMV imaging discussions around ultrasound, so it is very important to think about your image optimization and adjusting your five key your image controls: frequency, focal zone, depth, gain, and time gain compensation controls. I also recommend that the equipment has Doppler capabilities for assessing kind of vascular structures as well. And something that's probably thought of less is they mentioned a little bit about video clip quality. So this is all for reporting, which we'll come on to talking about, and especially where we're kind of looking at the uses of telemedicine and other forms of checking the images. It's very important to think about video clip quality and storage as well too. So it's just interestingly looking at the way that they sort of really highlight the use of different transducers, and it's something that can be a real benefit if you're getting into abdominal ultrasound exams and you're doing a lot of them, is considering whether having more transducers can help, and it can really make a difference for those superficial areas. And then again, those low frequency curvilinear transducers for deeper areas and larger patients can absolutely be invaluable. So yeah, some recommendations on patient preparation as well. The consensus suggests a minimum of 8 hours of fasting for the patient, although they recognise it's not always possible. Absolutely note that the hair coat must be clipped as well, and then they're recommending to prepare the skin with alcohol and applying coupling gel as well. And they also note that you should consider sedation for any patients that are anxious, aggressive, in pain, or where we're performing tissue sampling techniques for a lot of the situations where we think about them. But what I did is I popped in the kind of quote from the consensus there, that in general, sedation yields a higher quality and more efficient examinations. This is something I absolutely agree with, and it's something that I think people sometimes don't always think about for ultrasound, because ultrasound's very safe and you can perform it consciously. I think a lot of people tend to sort of consider ultrasound as one of these things. Well, we can do it consciously, so that's what we should aim to do. But as I said, as here and as you see, if you have sedated patients for it, it really does often make for a much higher quality examination. So it's always good to think about sedation as standard for these examinations. As mentioned, they talked about the use of Doppler imaging as well. So the routine should be used whenever there's questions related to the vascular system too. So as I said, Doppler is very, very useful in many situations. It's not just for echocardiography. There's a lot of reasons in the abdomen where Doppler can come in very handy for identifying structures, giving an idea of the sort of vascular perfusion, helping you differentiate between vascular structures and other structures, or between arteries and veins and things as well. So Doppler is hugely useful to have for abdominal imaging. And also, along with that, they talk about the sort of detailed reporting. So it's a big factor of this entire kind of consensus statement, is what should be considered standard, not only for performing the examination, but for the images that need to be collected as well too. And it's important as part of that that we're sort of reporting and noting those changes as well. So looking at the organ size, the shape, the echogenicity, whether there's normal or abnormal changes, anything that might limit the exam, any procedures you've performed. There's going to be a lot of reasons where, as you start to perform more abdominal ultrasound examinations, you may want to take tissue samples as well. And also then having some form of conclusion, some final assessment as well. So really good to think about a detailed examination. I've popped some images on the right of the screen here. So the top one's just a Doppler assessment of the left adrenal. It's quite nice. It's showing some of the vessels around there. We've also popped on just a copy of our ultrasound examination checklist. So this is something you can download from our website and use as well for your own reporting. And it may just form the start. It might be quite useful to look at it and then think about what you want for your own reports as well if you're not doing them, because as I said, the highlights in this paper are how important they are. As I mentioned, the image documentation is a big part of this. So they mentioned using DICOM format as standard. This is to preserve the image quality as well. So the DICOM files they're big files. They take up a lot of kind of memory, and they need specific viewers for viewing them. So many of the times when we're exporting images from our systems, if you're not specifically set up for using DICOM, you'll be doing it as other more sort of common picture formats and things, but they're often kind of compressed and lose some of the data. So they want to preserve that by suggesting that DICOM is used as standard. And they mentioned some of the kind of labeling that should go on it: the patient ID, the veterinary clinic, the date, the area that we're taking in any sort of measurements. So DICOM, again, if it's one of those things that you're starting to perform more examinations and doing them more routinely, is looking at whether that's something that you need to investigate or invest in, is some kind of picture archiving system, or what's known as a PAC system, for handling these DICOM files and helping to sort of send them as well for telemedicine too. So again, it's something that you can consider, but it's useful just looking at this sort of image documentation just to give an idea, because I think a lot of us vets are quite guilty at not probably storing as much kind of images and video clips as we need to as well. So in the paper, they mentioned using video clips for recording regional landmarks. So if you're looking at an area and you maybe can't specifically say exactly which part of the organ it is, or you want to send it away, you want to record some regional landmarks that guide people that are viewing the video clip to what the area you're is looking at. Interestingly, they often say that the clip should be 5 to 10 seconds in duration, so relatively long as well. It'd be interesting to look at your sort of own system and see how long that's set up to record for too. And then there's organ specific recommendations throughout this consensus statement as well. So that's what the image on the right is. Was just a list of the images and videos that they suggested for, say, just the liver at the top as well there. So you can see it's reasonably kind of comprehensive, with a sort of set of 7 stills and 3 video clips for certain, depending on the conditions you're investigating as well. And the consensus recommend that stills are recorded even if normal for documentation, and that you videos and stills for any abnormal findings as well too. So it's definitely something to consider if you're not routinely recording the patient images as well, and is to think about maybe getting into the habit of starting to record some of these as documenting the sort of normal organs that you're seeing as well. After that, we come on to the recommendations for the organs. So this is pretty detailed, and I think it's probably beyond the scope of the journal club to go through every single one in detail. Suffice to say, I mean, I think and I'll come back to this at the end, but if you're interested in abdominal ultrasonography, it's definitely worthwhile reading this paper and getting a look through of it, just to see the sort of information, the recommendations, because it's very useful to have these kind of statements to kind of guide what we should be aiming for as the sort of standard as well. But a big part of it is checking every structure in its entirety in 2 orthogonal planes. And although it's not mentioned specifically in the consensus statement, all this sort of image recording and looking through things in a standardized way kind of all feeds back to really considering your approach to abdominal ultrasonography. So it's thinking about how you approach them in practice, the sort of the order you want to work through the organs in, and how you want to sort of examine and document the images as you go. I always think that for myself, before I started doing ultrasound in a very routine way, I was often a little bit aimless with the way I approached the sort of patients. And when I started doing it more of a routine, it helped me start to develop that knowledge of where things are in the abdomen, and where the way that I wanted to work through it, and help me learn what sort of normal was as well, which was really beneficial. So really important to consider that sort of approach and method. And a big part of it that they mention in the consensus, and it's important to think about, just the use of intercostal spaces. So if you've got large, deep-chested patients, the cranial anatomy can also be very difficult to access and visualize subcostally in ultrasound. So it's important to have those intercostal spaces available to look at, say, cranial and dorsal parts of the liver, and in certain patients looking at the fundic or pyloric areas of the stomach as well. It'd be very challenging without using an intercostal space. So doing a rapid run through of some of the organs themselves as well, and just some quick kind of recommendations for it, things to think about. So the liver and the gallbladder, you can compare the echogenicity of the liver to the spleen and the falciform ligament, specifically falciform fat, sorry, in cats as well too. So you can compare that echogenicity. This is what the image on the right is. You've actually just got the liver sitting cranial adjacent to the spleen, and you can see that relative difference in the echogenicity, with the spleen being more hyperechoic as well too. And then we want to make an effort to try and specify where the lesions are in the liver, whether they're left, right, and central as well. And again, some of the vascular structures can be useful for kind of marking where certain lesions are too. And as noted, with coming to Doppler is very useful in the liver for differentiating any kind of dilated or abnormal biliary structures from vascular structures as well too. So some real utility for Doppler there. In the spleen, you want to be careful to ensure that the full extent is visualized. I always think of the sort of major abdominal organs. The spleen is one of the more difficult ones to visualize in its entirety. So again, it comes back to being methodical about how you approach it, looking at the sort of head of the spleen dorsally as well, and then ensuring that we're kind of following those borders and seeing every part of the spleen too. Interestingly, they mentioned sort of measurement of splenic thickness, so measuring it at the level of the hilus in a longitudinal plane. And there is a reference range for cats, and they do note in the paper that there isn't one for dogs, but they feel it's quite a useful measurement for actually tracking changes in the spleen over time as well. So they do recommend using that too, despite there no published reference range. Going on to the GI tract, again, it's about being detailed and seeing that we see every of the kind of different sections of the GI tract: stomach, pyloroduodenal junction, duodenum, jejunum, ileum, ileocecal junction, and colon as well. Again, it's really important to remember fasting for these patients. The 8 to 12 hours is what they mention for the examining the GI tract from in the consensus statement. And again, that's very helpful to get rid of a lot of the kind of content that's there, minimize the presence of gas, all of things that are going to create artifacts and can be obscure different areas of the GI tract. So this helps to give us the best chance to see as much of it as possible too. They mention you want to include as many jejunal segments as possible. That's what the image on the right is. We just got two parts of the jejunum just in a transverse section here, nicely showing the intestinal layering as well. So again, that comes back to being methodical. We talk about using your kind of grid or sort of sweep pattern to move through the abdomen and from cranial to caudal and ventral to dorsal, just trying to visualize as much of the jejunum as we can too. And as we go through, we want to note and evaluate the wall layering, the thickness of the wall, how the mucosa appears in terms of echogenicity, and the luminal content too as well. So remember, a lot of GI pathology that we're going to be looking at will present as changes in wall layering or changes in the wall thickness as well. The pancreas, they mentioned that the left lobe is hard to see in dogs and the right lobe is hard to see in cats. So in cats, you're more likely to actually be able to visualize the left lobe and body, whereas in dogs, it tends to be typically the right lobe have the most success at visualizing as well. So that's where it comes back to using those anatomic landmarks and actually documenting the landmarks in any images or videos you take. So for the right limb, you want to look at the duodenum. For the body of the pancreas, we want to look at the kind of pyloroduodenal junction, the pylorus and portal vein. And for the left limb in dogs, we're looking at the stomach and transverse colon. And in cats, you want to follow the stomach, spleen, splenic vein, and left kidney as well too. So it's just using those anatomic landmarks to find these areas and to document that you've visited and visualized them. Other organs include, they mention the urinary tract as well. So again, they mentioned measuring renal length and measuring that on a maximal longitudinal dimension in a sagittal or dorsal plane. So in either of those planes, getting the kidney to look as big as we can, and then measuring the renal length from kind of pole to pole as well too. And similarly, measuring renal pelvis dilation, we want to do that on a transverse plane image, ideally excluding the proximal ureter as well. And then again, a bit like the liver, they mentioned comparing the echogenicity of the kidney to other organs. So you can compare the cortical echogenicity of it, of the left kidney to the spleen and the right kidney to the caudate lobe of the liver. But remember, with any echogenicity measurements, there's always a bit of variability there, and a lot depends on the sort of machine setup, assuming you're not adjusting the gain or changing it between the organs. And whenever you do measure echogenicity, it's good to consider whether you could have pathology affecting multiple organs or the organ that you're actually comparing one to as well. Bit like the pancreas for the adrenals, you want to use your vascular landmarks for location, and you want to make sure you're documenting them as well. So if they're not visible, they should be stated as well too. I think it's always important, these small things, to remind ourselves that they can be very difficult to see, and that's where sort of knowing the landmarks, using them to document the areas that we expect them to occupy anatomically, can be very useful as well too. With the adrenals, if you're going to measure, we're measuring the maximal thickness at the caudal pole in a longitudinal plane, and there are reference ranges for that. Other organs, things to mention very quickly. With the genital tract, don't sort of ignore the genital organs in entire male and female patients, and in the areas where they say the ovarian pedicles or the cervical stump might be in a neutered patient as well too. So it's very important to think about these areas and include them. They actually do mention a little bit about pregnancy diagnosis, which is quite interesting. Just looking at that and saying from using it from 21 days in dogs, but it's more reliable from day 25 to 35 and from day 10 to 25 in cats. And they mentioned in the paper, quite a common thing we probably all recognize is that ultrasound is not reliable for quantifying size as well. So it's always useful to have that in these standards if you've ever got an owner who's pressurizing you to get the numbers. But yeah, not reliable as well. And then the lymph nodes and vessels too, they would state that the medial iliac and jejunal lymph nodes should be identified. So the jejunal being the sort of, and medial iliacs being some of the largest in the abdomen as well. So it'd be part of a standard exam, and we can measure their short axis diameter and compare that to reference ranges as well. But for the other lymph node structures, we expect them not to be visible. But again, it's using landmarks for those areas, and where we do see them, it's considering the areas that they might drain as well too. So that was a super quick run through the recommendations of this paper, this consensus statement as well. So how clinically relevant is it? Extremely. So if you're interested in abdominal ultrasound examination, I would encourage you to get a copy, look through it, and look at the sort of what they're sort of suggesting in terms of the way we document the images, the sort of the areas of each organ that are being examined as well. So it's worthwhile having a look through and using that as a guide, as sort of framework for it as well. The important parts to say it is to use this to think about your routine approach, and the things that go hand in hand in that is also just how we're then reporting and recording any findings and the images that go along with that. So it's worthwhile to sort of take this and think, we want this information from our abdominal ultrasound examinations. What can we do in practice to help us get that information each time and work through it in a nice standard routine way and get the same images each time as well too. I sometimes think with consensus statements like this that they can sometimes seem a bit daunting, especially if you're just starting out, you're not that experienced at using ultrasound. Reading a consensus statement where they talk about things like looking at parts of the vascular anatomy or the more detailed areas can be quite daunting. It's important to remember that this standardization consensus statement is written by board certified radiologists in a way to sort of to kind of standardize the exam for board certified radiologists as well. And that if you're in general practice, you're not that familiar with ultrasound or you don't use it that much, the kind of key messages are still there, is thinking about how we routinely approach our patients as well. And these are all things that we can work up to over time as well. Ultrasound is a practical skill. It takes time to develop and learn it. So when we start off, there may be some of these things that we do find challenging, but with time and experience, and in some cases, yes, the right equipment, you can get to that level and build up to it. So it's about sort of learning from this and moving forwards. But I think it is certainly very relevant to us as sort of imagers and kind of general practice as well. With that in mind, I'm just going to do a bit of a sort of shameless plug for ourselves at the IMV team. You may be aware, you may not, we've just recently launched our new CPD system as well. As part of that, we do actually have a new online course as an introduction to abdominal ultrasound. So if you're just starting off or you want to brush up on those techniques and start moving towards performing these exams in a very standard way, that is available too. So if you're in the UK, this is something that you can purchase and perform completely online as well. The screenshots on the screen at the moment are all different bits of the content. So we've got lots of interactive content, animations, videos to take you through the whole thing from start to finish. So if you are interested in ultrasound, but you're wondering where to kind of begin or want to kind of learn a bit more, this is a great place to start, and you can check it out at the web link on the screen just now. That's it. So thank you very much for listening to another month's IMV Imaging Journal Club. Again, if you want to get a question, you got in touch, you can reach us at clinical@imv-imaging.com, or you can pop your question in the Q&A box. Thanks for listening. We'll hopefully see you again for another Journal Club episode. And otherwise, yes, thank you and goodbye.